Right. Good morning, everyone. Or sorry, should I say good afternoon? And actually, my screen has done something, and I can't see anyone. So anyway, welcome to the Health Research from Home webinar. And yeah, this is me. I'm the patient public co-investigator on Health Research from Home, and I'm going to be your chair today, along with Coral, who's our project coordinator. So this is the agenda for today. So first, I'm just going to run over some housekeeping. So we're going to be recording today's webinar, and the recording will be paused during the question and answer session. And then we're going to upload the recording to our YouTube channel next week. And you will find a link to the YouTube channel in the webinar follow-up email. And we really encourage you to submit questions in the Q&A box throughout the webinar. We're going to have everyone's mics muted for the presentation, and the host will unmute anyone who would like to ask a question live during the question and answer. And please feel free to use the chat box to interact with each other or to ask Coral for any technical support. So it's my pleasure to introduce Matt and Lorna, who are going to be talking about co-producing research with children and young people. And I particularly welcome this session on co-production, as well as the technical stuff, and especially co-production is very context specific, and I'm really interested to hear about the context in which they have co-produced this research. So anyway, I will stop sharing and hand over to you, Matt.
Thanks very much, Lynn. Let me do the usual clicking. Okay, hi folks. Thank you for joining, if anyone's out there, and sincere thanks to the Health Research from Home team for this opportunity to explain our approaches to health research in homes. Our refers to the team, the Sleep Detectives, which spans 3 universities and 2 national charities, and most importantly, a network of families living with complex genetic conditions. So I'm going to explain why we're up to what we are. I'm going to explain some of the things we've done wrong in the past, and more recently, how we've tried to rectify them. The overarching goal of the Sleep Detectives project is to understand the neurobiology underlying the interrelationships between cognition, sleep, and mental illness. And I would hazard a guess that almost everyone listening has experienced that neurobiology to some extent. We all know that it's easier to cope with life after a good night's sleep. And conversely, it's harder to cope with life after a bad night's sleep. And I should know, because I had to get up at 4:30 this morning to catch a flight. Of course, if bad nights sleep recur, then that makes it even harder to cope with life. And I'm sure you all are aware that some form of sleep disruption is associated with essentially every brain disease, including mental illness and psychiatric disorders. So our approach to unpicking these neural mechanisms relies on this translational framework, which bridges between mechanistic studies in behaving rodents, rats and mice, and studies in the homes of people. The central method that we use is in vivo electrophysiology, so recording of brain activity, but obviously in different shapes and forms, whether you're a rat, a mouse, or a human. I'm not going to talk about the rodent stuff today, only to note that there's a long history of tracking behavior and physiology over extended timescales in rodent homes or home cages. And it's interesting to think about at least how analyses of those data might interrelate with the kind of work we're doing with humans nowadays. We typically bridge between rodents and humans using computational methods. I'll also set those aside for today's webinar. Again, just to note that thanks to those computational methods, we can take relatively accessible recordings of brain activity, so measured using scalp EEG, electrodes non-invasively stuck to the scalp in some shape or form, and yet we can make detailed synaptic level inferences based on computational models. So why is sleep in the thick of it here? Why should we apply this sort of framework through the lens of sleep? Well, again, I'm sure you all know that sleep matters to all brains, no matter how young or old they are. Although obviously sleep's contributions to our health vary across the lifespan. So if you're a newborn, then welcome to the world. And sleep is particularly important for you because the structured rhythmic brain activity during sleep nurtures brain development. It fine-tunes the synaptic connectivity that ultimately gives rise to a mature brain somewhere towards the end of adolescence. So throughout childhood and adolescence, sleep is vital and plays contributions to brain development, and therefore sleep disruption during those earlier stages of life can have lasting consequences. That's something that Lorna's going to touch on in a few minutes. Alongside brain development, of course, sleep contributes to many brain and bodily functions, including but not limited to cognition, emotional regulation, metabolism, immunology, and so on. And I'm not trying to make the case that sleep is the answer to everything or the root of all evil in the case of disease, but it's almost always in the mix. And that's why sleep matters to all of us, I think. Sleep is always contributing to how we feel, how we behave, to our physiology. And so it deserves our attention, I think, and should be measured properly. As I mentioned, sleep disruption is associated with almost every brain disease. And unfortunately, these demonstrative quotes capture that. This is discussing parents whose kids have trouble sleeping, who describe constant battles, giving rise to low tolerance and aggression, and inability to attend or focus at school. The solutions are few and far between, and in many cases, parents end up co-sleeping with children, for example, because they just need to do something to get some rest overnight. So sleep is sleep disruption is a big problem for a lot of people, unfortunately. Here's a link to a couple of reviews I've co-authored over the past couple of years. The QR code there links to a Wellcome report reflecting on the importance of sleep and circadian rhythm disruption and its relationships to mental health, which do afford many opportunities, which are exciting, I think. So there is a positive outcome here. The particular context of those quotes was from families living with complex genetic conditions. I referred to the two charities, Max Appeal and Unique, who support those families. And the particular conditions we're interested in are copy number variants. So these are relatively rare chromosomal mutations where carriers of those mutations are either missing a little chunk of DNA or have an extra little chunk of DNA, which varies the gene dosage of typically tens of genes. Now, a dozen or more of these copy number variants, or CNVs, are associated with psychiatric outcomes. So, for example, the commonest of the CNVs we're working with, 22q11.2 deletion syndrome, is the strongest known genetic risk factor for schizophrenia. So as shown on the graph on the right, if you're diagnosed with 22q, then you have a 40% chance of ultimately being diagnosed with schizophrenia, typically in late adolescence or early adulthood. And that contrasts with the general population who have a 1% chance of that schizophrenia diagnosis. So those are bad odds. And obviously, we'd like to understand how we can help and perhaps keep people on track despite their genotype. And the central hypothesis of the sleep detectives team is that sleep disruption might mediate this association or some of this association between genotype and psychiatric outcomes. Again, I'm not saying that sleep is the cause of all these problems, but we know that the carriers of these CNVs sleep badly from a very early age, and we think that might be exacerbating their problems and reducing their quality of life. Now, this project really came about thanks to Marianne van den Brie, who's based in Cardiff, who was giving a talk about her CNV research when a group of families approached her afterwards and said, listen, our kids sleep terribly, but no one seems to care. Nobody really believes us. No one's paying much attention to this in the clinic. Can you help? That's really what launched this sleeping ship. It was Marianne's expertise, which led to our collaboration. So in the bad old days, our approach to investigating sleep in these populations was quite traditional, let's say. It was very much a case of scientists thinks they know what should be done and rocks up and does it with ethical consent, of course, rather than involving any meaningful co-design, despite the fact that the project was launched because of essentially a request from families. So the first thing we did, Marianne's team, was based on questionnaires, which have their uses. but are always prone to misinterpretation. There aren't many parents who claim their kids sleep extremely well, for example. Nevertheless, interviewing parents of kids with CNVs, they described restless sleep and insomnia. And those sleep disturbances did associate with psychiatric symptoms in these young kids, so particularly ADHD-related symptoms and impaired cognition. To understand the mechanisms that might be driving these effects, then the baddie neuroscientists like me arrive, and I'm ashamed to say that we rocked up at people's homes. Again, we did ask their permission first, with suitcases full of EEG equipment. This work was done by some intrepid PhD students, Haley and Chris, and postdocs at the time, Uli and Nick. Wired them up with high-density EEG kits, as shown in this picture, this pair of siblings here. They slept with those kits on overnight and kept those kits on the following day as well. So it's a 24-hour EEG recording with some cognitive tests in the mix. So that screenshot shows a paired associate type task. Now, we're incredibly grateful for the families for tolerating that, which they did incredibly well. Nevertheless, this approach is not sustainable. It doesn't give us the longitudinal view of how early sleep disruption might culminate in psychiatric symptoms later in life. We knew that, but this cross-sectional study was a starting point, and the paper cited at the bottom in eLife reflects some important mechanistic insights into the abnormal brain activity seen overnight in these kids. So that was the bad old days. Now we're in the business of fixing it, not only for reasons of sort of sustainability and ethical considerations, also enabled by the advance of sleep technologies, which are growing exponentially nowadays. So there are nearable devices you can pop under the mattress, for example. There are wrist-worn devices. Both of those don't measure sleep. They can be used to infer sleep, but they're not measuring it directly. But there are also wearable EEG devices like this headband, which might bridge that gap between a nearable estimate and a wearable measure of sleep. So lots of exciting stuff afoot, although lots of caveats as well, particularly with consumer devices, particularly because almost none of these devices are validated in children. Nevertheless, this was enough to launch the Sleep Detectives project, which was generously funded by Wellcome for 3 years. And this picture is one of our first co-design workshops. The first work package, the foundation of this entire project, is developing a network of lived experience experts and other stakeholders, the families and the charities in particular, who can help us design a method that really does allow us to quantify their sleep longitudinally in a way that aligns with their priorities and is accessible and acceptable to them. So we organized 2 workshops, each for about 20 families, so 30 to 40 kids at each. This is the photo of the first one, spring day in Bristol. And I'm going to spend the next couple of slides explaining our sort of co-designed approach to co-design and how we came upon those workshops. So the first thing we wanted to convene was a lived experience advisory panel, or a LEAP. And we turned to our friends and collaborators in Cardiff, Hannah and Jess in particular, who already had a lot of experience of working with these CNV families. So they'd already built up trust and a productive working relationship. So that was a great starting point. Ultimately, then we advertised for people who might be interested and convened a LEAP that involves 9 parents and carers, variously 1 to 4 kids who join in the background of our online LEAP panel meetings, which is normally great fun. 2 CEOs of the charities, Max Appeal and Unique, which support families with these genetic conditions. And about 6 of the research team are normally present at any given panel meeting. So our first panel meetings were about explaining the project and asking for advice on whether and how to organize these co-design workshops. The families were very keen that we should develop approachable narratives as to why we wanted to do this research and to gauge people's interest and gain their insights. So with Jess's help in particular, we did things like develop social stories, animated videos explaining what goes on in the brain during sleep, that kind of stuff, to try and capture people's interest and explain in accessible terms what we were up to. We also wanted to prepare people. You can't just parachute them into a busy workshop and expect them to get on with co-design. It can be quite an anxiogenic environment. It's a new environment for people. So we sent photos and walkthrough videos of the venue. We sent sensory maps explaining what was going to be going on in each room. We sent photos of the security staff who welcome people into the building at the University of Bristol, for example. We had quiet rooms, we had cafes. The most popular room was full of Lego. Most of the researchers also wanted to spend most of the weekend there during both the workshops. I don't want to trivialize it. Essentially, we just had a fantastic time. It was really great fun. But it was thanks to all this preparation that the people were comfortable. I think we also sent videos of the team members. So I'm not going to show you the video, but this is me being a clown in bed with the mascot glove puppet for the study, Ottilie, the sleep detective. And we paired up each kid who attended with a buddy who they were introduced to before their arrival. So they knew who to expect and they knew who to go to if they needed any help or support during the day. Often they didn't want to let go of their buddies at the end of the weekend. It was really lovely to watch. Of course, all this comes at a cost of people's time and expenses. We booked and arranged and paid for all the travel and accommodation and sustenance throughout the weekend. Of course, we pay the LEAP panel members for their time, whether that's at a meeting or in giving feedback on materials. That's according to NIHR guidelines. We give the kids vouchers for their involvement as well. So the total budget for this 3-year project for the PPIE element is £36,000. Just a note that if people are interested in this kind of approach, then you do have to budget for it properly. I forgot to say up in the top right is Snoozy the robot, who is specially commissioned to explain some of the computational aspects of the work, and I must say did an excellent job of it. So one of the things we did during the workshops, there was a room sort of allocated to the cognitive tests that we had some ideas about using. That was led by Chris Gerald, who's a psychologist in Bristol, and Meg, who was a postdoc on the project at the time. So for example, we sat the kids down with pen and paper and asked them to sketch some little creatures they might like to use in the tasks. They could use AI to generate those creatures. They could try out the tasks, which are based on touchscreen format on an iPad. They gave us lots of feedback on the soundscape that they wanted to use, on the kinds of rewards, the little gems they like to win. We developed this map so they can sort of track their progress through the tasks over multiple days. Prior to the workshop, we'd had some feedback from the Bristol Young Persons Advisory Group, so we were fairly confident that our tasks would be appropriate for kids between 8 and 18 years of age, which isn't entirely straightforward. But really, the workshops were hugely important for us in refining the tasks and really understanding how to titrate levels of difficulty. And for example, it's because of all that these tasks have worked so well since, I think. We also wanted to introduce the notion of recording brain activity with an EEG headband. And rather than just plonk the headband on and hope people like wiggly lines as much as I do, we used this game, which is called MindFlex. So here's a young man and his dad who are battling one another. They're using their brain waves recorded through these EEG headbands to move a floating polystyrene ball back and forth across this panel. Again, kids absolutely loved it. There was 1 out of 40 who wasn't sure about putting the headband on, but otherwise they all were diving in. And once they got used to that idea, you might see there's a bed in the background so they could get used to lying down with stuff on their heads and on their wrists and so on. And that's how we got really sort of hands-on feedback about the kinds of devices they might like us to use in the full study. So after these 2 workshops, we had a sort of pilot protocol. We then ran that protocol in 3 primary schools in the Bristol area, targeting kids of a median age around 10 years of age. Gratifyingly, Westbury Park is where I went to primary school, so it's very nice to go back to your primary school and ask if you can experiment on the kids. We used this EEG headband shown in the top right called the Muse S. And the panels here just show sort of signatures of brain activity over multiple nights from the kids who we asked to wear the sleep detectives kit for 7 consecutive nights if they could. So highlighted in the dark red, for example, there are 5 consecutive nights from 1 participant. And the profile of these power spectra. This tells us that that individual's brain activity is consistent from night to night. We all have an individual fingerprint of brain activity during sleep. So we were able to capture some of the data we wanted, but not all of it. This headband was a bit temperamental. It tended to work loose over the course of the night. So on the back of the workshops and the back of this pilot study, we've sort of further adopted our protocol. So the final sleep detectives kit involves a Fitbit Inspire 3 worn continuously for 7 days and nights. That was the device, the consumer device that gets preferred over research grade devices. That QR code links to an open source pipeline we've developed for analysis of Fitbit's actigraphy data, if you're interested in circadian rhythms, for example. We run the tasks on an iPad, which also encompasses a sleep diary and a daily activity log. We then adopted, and this is thanks to Lorna and the team up in Edinburgh, this bedside radar device that Lorna's going to expand on, the Somnify device, which just sits passively in the bedroom. And for the EEG recording, we're now using this Click EEG device, which is a newly developed gadget, which is an adhesive that sticks on the forehead rather than being a headband. We've had feedback that it's much more comfortable to sleep in. It certainly gives us much better quality EEG. We've learned that a little merch goes a long way. So we've also developed these study customized EEG electrode stickers and very popular toweling wristbands go over the Fitbit. And here's the evidence that it works. This is quotes from some of our participants, Maddie, for example, who loved meeting the other kids. And actually, she cried at the end of running the 1 week protocol because she wanted to carry on for longer. I take that as a good sign. The parents have loved it as well. What's been most important for the parents, I think, is the opportunity to meet one another. Often they never met another family with this particular rare syndrome. So that's been heartening. Some of them have even gone on holiday together. That's the kind of outcome we're most proud of, I think. So to sum up, sleep and circadian mechanisms are in the mix in almost every mental illness. Not causal, but often exacerbating the problems of people. They really matter to people, which is why longitudinal at-home studies are vital. And we do need long time course studies to understand what's going on. But those studies, particularly I expect in children and young people, just won't work unless they're co-designed. Sleep gadgets are great. They open lots of opportunities, but they're rarely validated with children. And there are some complexities to working with commercial ventures, for example, I'm happy to talk about. The most important message, though, is that co-working with lived experience experts isn't only necessary, it's actually wonderful. It's been a joyful process for us that has made our science not just better, but more kind of life-affirming, I guess. So thanks for listening. Thanks to the Sleep Detectives team shown here in all their glory. And I look forward to your questions. Hand over to Lorna.
Thanks, Matt. Well, Lorna's just getting ready. That was such a fantastic presentation. And you mentioned all the essential ingredients for co-production, the trust, the relationships, the preparation, the time, and the resources, which just co-production can't thrive without. Now, Lorna.
There we go. Hopefully that's all working now. But yeah, thank you so much for Matt. Matt. That was really interesting as well, and hopefully some of this work will complement what you've been talking about as well. So yeah, I'm also going to focus on a slightly separate method called radar devices for monitoring sleep. So just to give a brief outline, I'll mostly cover the ambient teen sleep study, which was a feasibility study funded by the MRC in the lead up to the adolescent health study to assess if radar sensing was feasible and accepted by adolescents. But I'll also try to cover more generally the potential for radar sensors to be used for continuous longitudinal measurement in other populations as well. And then lastly, finish up with the importance of the co-production throughout this work. So I think I don't need to necessarily explain to this audience that wearables have been really great tools to gain insights into everyday health, and will continue to be really useful for understanding health out and about and in home settings. But specifically when it comes to monitoring sleep, there are some times when wearables are maybe less acceptable. Even kind of the most typical watch wearer may take off all their accessories before they go to sleep for comfort. Children and adolescents are maybe less likely to wear wearables over longer time frames, and also those with older adults that may have Alzheimer's or dementia are likely to remove wearables for longer time frames. And if anything kind of like charging devices is required, then remembering to put these devices back on may also become more of a challenge at times. Other specific populations, such as neurodivergent individuals that may experience sensory overload, or anyone with skin sensitivities, again, specifically during sleep, are less likely to wear these wearables especially over longer time frames. So typically when the wearables are used for monitoring sleep, they often are used for shorter durations, which they're really good for collecting kind of 1 to 2 weeks of sleep data. But if we want to look at sleep over longer time frames, to be able to kind of capture these elements that might be missed, such as key life events and the associated changes in sleep timings, then we maybe need methods that can be used passively over longer time frames. So, for example, over puberty, if we're interested in sleep patterns and other health outcomes, such as mental health, over the course of puberty and adolescence, we may want to look at other alternative options. So that introduces radar sensing, which it has the potential to measure sleep over continuously, passive, and in a contactless way. So the radar sensor typically sits on the bedside. For young people, we had lots of different mounting options, which our co-producers helped with, such as wall mounts or gorilla mounts that attach to bed frames for those that have bunk beds, raised beds, all these wonderful bedroom arrangements. And it measures sleep by monitoring whole body movement and respiratory rates. And they often also have other inbuilt sensors to monitor the room environment, such as light, sound, and temperature and air quality. In the work that we've done, we use the sensor on the left-hand side here, the Somnify, this one's called. But these devices are less familiar to people, and so we first do need to address if they're feasible and accepted by target populations. An initial response can often be privacy concerns. On the ambient teen sleep study, I did have a parent of a participant, after setting up the device in a checkup call with me a week or so later, they'd said, oh, the cat was in the bedroom and I shouted for it to get out. And then I wondered, did the device record that audio, and wanted to know, because they make it very clear they were shouting at the cat. And so we do need to work with individuals to make sure that we use the best approach with this new technology and explain what they can and they cannot measure. So in that instance, we explain that what we look at from the audio side of things is how loud was the sound, not any kind of specific speech. So specifically for the ambient teen sleep study, we recruited 48 young people split across 3 age brackets, ages 8 to 11, 12 to 15 years, and 16 to 18-year-olds. They installed the radar sensor in their bedroom for 4 weeks, and we also asked them for 2 of those weeks to wear an accelerometer and to complete a written sleep diary. We did include lots of co-production, which I'll talk about towards the end of this presentation. The key result I want to kind of draw your attention to just now is looking at data loss. So when we compare the radar sensor and the accelerometer, we've kind of broadly categorized these into 3 areas of expected data. So from the first night that they used the device to the last night that they used the device, how many nights were available to collect data on, which obviously was different for each device. And then looking at the amount of data that we were able to collect. So we collected 90% on average from the radar sensor, which shows we lost about 10%, mostly from participants not sleeping in their own bed, on sleepovers or on holidays, that type of thing. Whereas we lost that bit more data from the accelerometer, from largely participants starting wearing the accelerometer, but it causing irritation or discomfort, and so late towards the end of the weeks, they decided to take it off earlier than we would have liked. And then taking it one step further, looking at how much data was clean and usable from each method. We lost maybe a further 3% of data from the radar sensor. That's often just the odd maybe night that there's issues with device signals and other small things that interfered. But we lost again a much bigger percentage of loss, a further kind of 19% data loss from the accelerometer in terms of high non-wear time, which meant there would be a different method that we'd have to use to determine the sleep timings. So overall, this just shows that the potential for the radar sensor, one, in the sense that we're using it over longer time frames, but two, that it also has the potential to be able to improve compliance and adherence rates throughout the study as well. So some future steps for radar sensing is that, as Matt also mentioned, that radar sensors aren't validated in young people, and so that's definitely a step against validation against polysomnography for radar sensors moving forward. In this ambient teen sleep study, we did only use the radar sensor for 4 weeks, and we certainly want to increase that duration to have continuous measurement over months and years. So just to highlight a few other studies at the University of Edinburgh, where we're using radar sensing over 6 months, 12 months, 18 months, over much longer time frames. So ambient BD, looking at sleep in bipolar patients. The Hub for Metabolic Psychiatry has a study called MetSci, looking at sleep in those with severe mental illness, and the Mental Health in the Moment study, looking at mental health outcomes in young people. But alongside the monitoring sleep over longer timeframes, we also need to make sure that we have concurrent longitudinal measurement of other health outcomes so that we can look at those trends and patterns over time. So lastly, to touch on the co-production element, we had a pre-study young person advisory group with young people from each of the different age brackets who helped us design the instruction materials that young people would get. They were very keen that we had video options of everything. So we have our Ambient Teens Sleep Study YouTube channel. And they really wanted to actually engage throughout the study much more frequently. So we included these check-in calls where each week of participation in the study, young people were invited to a 15-minute call with a member of the research team where they could check in, let us know how they were getting on with the study, and also they could learn a little bit about sleep, what different sleep terms were, what sleep efficiency, and that sort of thing. At the end of the participation, all participants were invited to take part as a citizen scientist activity. So the images on screen here are what we call our product reviewer activity, where young people in their own creative ways could give us feedback on the different devices and their study participation. We had videos from young people, and all of these are available on our study website as well, which you can take a closer look at. And then it was also really important that we gave back to the young people as well, and some of the young people in our co-production in our first pre-study WIPAG did help us to decide on making sure that we had certificates and thank you letters for their participation. We also offered young people vouchers that were up to £25 for taking part in the study, and those that took part in the WIPAGs also received were offered additional vouchers. But one of the key things that young people said was really important was including seeing the data. So at the end of the study, they received this individualized summary sleep report that was very summary level over multiple days, that they could see their data, some of their own data that they got to take home with them. So lastly, the last co-production element was that we invited everyone that took part in citizen science to take part in a post-study WIPAG, where they helped us to create a video series where they disseminated some of the results from the study in their own way. So 5 young people created 4 videos that are on our YouTube channel, and I'm biased, but very worth a watch. They did a really good job of that, sharing some of the results to other young people. So lastly, just to say thank you for everyone that's been part of this, and especially our co-producers. And here's some kind of links to, I suppose, a lot of the things I've already spoken about, especially those other studies using radar sensing as well.
Wonderful. Thank you so much for two brilliant presentations, and actually, Lorna, I'm just reflecting on, like, we know what's important in research, don't we? And this thing about the transparency and giving results back to participants and keeping people informed, you know, because actually, why wouldn't you want that as a participant in research? That's great. Such wonderful presentations and questions and whatever. And now I'm not going to share my screen again before I pass over to you, Shuai, just to give us an update on one of the health research from home driver projects, the Africa one. So over to you, Shuai.
Yeah, thank you, Lee. Can you see my slide okay?
Yes.
All right. Hello, everyone. Thank you again for joining our webinar. And I'm excited to give you an update on the Paprika project. My name is Zhuai Shao, the postdoc researcher on this project. Today, I will walk you through our latest progress. So let's do a quick recap. Paprika stands for Physical Activity Patterns After Knee Arthroplasty. It's one of the driver projects under Health Research from Home. In this driver project, our aim is to understand how physical activity changes following knee replacement surgery. Clinically, the goal is to provide insights that can help patients and clinicians make informed decisions before surgery. From research perspective, we are conducting a retrospective cohort study using existing data from wearables and smartphones, which we are linking with NIHR data to gain new insights. This approach gives us a valuable view into post-surgery activity and recovery patterns. To reach our goal, we are following a simple staged plan that keeps us moving steadily. If you joined the last Paprika updates, you will remember we were at stage 5. We are still here, but we have completed the final check on the data collection pipeline, and it's ready to go live this month. In this webinar, I will share some experience from our internal testing of activity data collection and the challenges in the data. So let's do a quick review of what we collect, the time window, and the data. We collect data from Apple, both the Apple Watch and iPhone, plus Fitbit and Oura Ring. We will collect up to 18 months data per participant within the time window, July 1st, 2016 to the end of 2024. The type of data we collected would be activity metrics such as steps, distance, activity minutes, energy, and also heart rate. Platform, we will collect data through the radar base developed by the King's College London. Okay, on the left is what participants see when connecting Fitbit. On the right is exactly what we receive if they consent. We can retrieve daily summaries like steps, distance, energy, heart rate. Also, we can get intraday data within the Fitbit. The difference is intraday data will provide us rich data in each hour, so we can see patterns across the day. Next is our ring, user selection list on the left and data tabs on the right. You may notice that Aura groups sleep and activity in the same consent category. Even when that category is enabled, for this study, we only retrieve activity-related data. Because we want to explore the surgery recovery patterns, we may only interested in activity data, and we will filter out anything that isn't activity before analysis. Fitbit and Oura Ring data can be collected through web APIs. It will be just a simple link with button and agree on the consent. The process is very straightforward and easy to follow. But for Apple, we may need to use the iOS app to connect the health kit. Instead of pulling data from cloud server, Apple data stored in the participant's own device. which means the participants need to download a new app on their iPhone and go through the steps within the app to connect their data. To make a setup easy and smooth, we give people 3 types of help: a web walkthrough, a downloadable PDF, and short videos. On the website, it's step-by-step guide with screenshots. The PDF user guide mirrors the website but works offline. It has a content page, quick start, and a full walkthrough, handy for anyone who prefers a printable guide. And for visual learners, we've got short how-to videos to follow in real time. Okay, great. Data's flowing. Now the real work begins, the data processing. You may know that once you collect data, data collects problems. So first, we need to make different devices speak the same language, simulate time and the level of details. You can see the step data from Apple comes within the day, but at uneven gaps. Sometimes every 10 minutes, sometimes by hours. And Fitbit step data provides even bigger gaps across days. For those cross-days gaps, we need to explore a method for gap filling, nowhere detection, and when to leave a day as missing. Next is the multi-device challenge. People often wear more than one device. We need to line up their timeline and decide how to merge the data. Even within the Apple, the iPhone and Apple Watch can report different step counts for the same day. Across brands, Apple and Fitbit, they use different algorithms. So when both are wrong, we need to be more careful to explore the more reliable stream and avoid double counting. And also missing data. It's a headache for many studies, including Paprika, because we work retrospectively with data from participants' own device in a free living conditions. Some days they just do not wear their device, or the device is on charge for hours. So we have got a very real missing data problem to spot and handle. There is one example. You can see that this participant has data from both Apple and Fitbit. The top plot starts in 2021, the bottom line with the 2022. In the overlap, both devices cover the same days. Fitbit's daily summaries, the middle row looks sparse, while the intraday streams, the bottom row looks complete. You may think like that, but here's the catch. Fitbit intraday data always return something for the time window you ask for, even it's just the rows of zeros. Those zeros can mean different things: a real zero, no steps, the device wasn't worn, or maybe a device sync issue. So data present doesn't always mean activity recorded. We are refining our data processing, testing ways to handle multi-device days, missing data, and other collection issues. We will share the approach we adopt once it's validated. All right, to wrap up, Paprika is going live this month. In our next webinar, we will share early lessons from recruitment and data management. Plus, we are handling the wearable and the smartphone data in practice. So what worked and what doesn't, and the tips you can use. So I look forward to seeing you next time and share more from our study. Thank you.
Thanks, Wai. That was a great update. And actually, as a patient-public partner involved, it's been like gobsmacking in a way. You know, the amount of work and effort that has gone into running, and I personally have learned so much through this process. Right, I'm going to share again, hopefully. Yep, there we are. Oops. Okay, and sorry, apologies. So we have, I will just, yes, so announcement. So Thank you to everyone who's already signed up for Connect. And although the event is sold out, don't worry, we'll be releasing more tickets in the coming months. So to be in with a chance, please join up to the wait list now via the QR code, or there'll be a link in the webinar follow-up email. And also, so tickets will be prioritised for people that want to compete for the Ken Brothman Award. So this is about showcasing your research. So if you're working on population health research using smartphones and wearables, apply now for the chance to present at our Connect event in 2026. And here are the details are on the screen, and you need to apply by the 7th of December. Our next webinar is going to be on the 14th of January with Jake and Ella from Google, and we will be circulating more details about that nearer the time. And just a reminder that all our webinars are on our YouTube channel. So it's a fantastic resource, so please visit it to see the other webinars that we have done. And these are our resources, QR codes to our resources, the GitHub where all the codes and wherever are, our website, and also our LinkedIn page. And that's it. So I think all that remains is for me to, so Coral has put up the poll, and again, just a massive thank you to Matt and Lorna for coming and speaking about and sharing the joys and challenges of co-producing, and of course the technical stuff as well, which is really interesting. And I hope to see you again at the next webinar, and you've got 2 minutes back. Okay, thank you. Bye.